So, good evening, all. I'm Simon Bryson. I'm the co-founder and chief exec of Pravica, and it's my pleasure to offer you a very warm welcome to this evening's educational meeting. It's with a very special thanks to our esteemed guest speakers, Dr. Rahul Bharat and Francesca Napolitano. We'll be focusing on secretion management in pediatric patients with neurodisability. Okay, so it is with those formalities out of the way, I'll be kicking off this evening's session with a brief introduction to paediatric medicines and to give you some flavour of how we approach the unmet need for a treatment of chronic drooling in children. So I'm just going to share my screen with everybody. So, background of Pravica. We're a paediatric-focused pharmaceutical company. We prioritise the improvement of lives of children in Europe and the UK through the provision of the licensing of the right medicines. We say that a child's shoes should be designed to fit their little feet. The medicines should be designed to fit their bodies too. And we take very close care and attention to work with doctors, carers and patients to produce medicines that specifically meet and designed to address the needs of the child, those unmet needs of the child. We have been established since 2010. We're a dynamic team. We're very passionate about what we do and focusing on developing these innovative medicines. Currently, over half of medicines that are taken are often in the wrong format, are not licensed for children. And it's our job to build that evidence base within Pravica to deliver that, to facilitate evidence-based prescribing. And we have a portfolio of development products in paediatrics in active pipeline today. So the way I like to describe the situation of delivering innovative paediatric medicine is, if you look on the left-hand side of the slide, I consider it as a bit of a broken jigsaw. Often clinical particulars may be missing, the evidence base might not be there, the formulation may be less than ideal, but of course really important to have the child and the parent engage with taking the medicine. And we turn that into a complete jigsaw puzzle, fixed with paediatric optimized medicine, new clinical data blended with pre-existing clinical data, addressing that unmet need and delivering an evidence-based product package that can be prescribed for the child. It's not an easy problem to solve. It's multifactorial. You'll be very familiar with this. Developing a paediatric patient-centered medicine in an acceptable dose form with those right organoleptic properties incorporating preference is really tricky. Getting the profile of smell, taste, texture, appearance, and dose forming optimal to facilitate medication adherence so that it's convenient and easy to measure and deliver that correct dose. And importantly, taken administered without modification, which so often is the case. And that packaged together for the appropriate age, disease state or medical condition as a product, delivering a safety and efficacy package. So our goal is to deliver that, delivering license optimized medicines with those key criteria that underpins it, that enables medical information on those licensed products, post-marketing pharmacovigilance, so that you get the very best products and support for your child. We go through a centralized authorization program through the European Medicines Agency for much of our medicines. The product Sional that I want to just mention shortly is authorized through the European Medicines Agency's process. It's considered the gold standard. PUMA stands for Pediatric Use Marketing Authorization, and it is comprised like this. It's a common technical document with all the required particulars that provide a full development program, describes full quality, efficacy, safety, tox package, describes manufacturing and the important shelf life and stability of the product as well before that product is approved and is allowed to be placed on the market. To date, there have been 6 PUMA, Pediatric Use Marketing Authorizations. You'll see them on the screen here. Some of you will be familiar with. Importantly, Sional on the top left-hand side. So a little bit about Sional before I wrap up. It's a glycopyrronium bromide solution, 400 microgram per mil as glycopyrronium bromide, equivalent to 320 micrograms as the glycopyrronium active base. It's the first product to be approved for this indication across Europe, and it's the only product licensed European-wide for the symptomatic treatment of severe sialorrhea in children aged 3 years and older with chronic neurological disorders. It's a concentrated solution, 2 milligrams per 5 ml of glycopyrronium bromide, for relatively contained volume to swallow, which is important, of course, for children with swallowing difficulties and challenges. It's a clear, colourless, raspberry-flavoured solution provided with an oral dosing syringe and administered 3 times a day. We also have an active pipeline across a number of therapy areas in cardiovascular, immunology, neurology, oncology, and gastroenterology, which we'll be bringing to the market over the next one will be next year, and then the outward years from there. And of course, we have a lot of focus on getting that dose form optimized. So innovative dose forms like oral dispersible mini tablets, which effectively are like a very small Hermaceta or Sweetex tablet, rapidly dispersed on the child's tongue, enabling that much easier dosing of some very challenging to deliver medicines, alongside, of course, the traditional liquid formulation technologies that are so often needed to deliver the appropriate medicine to a child. So this bit I have to put up because I've mentioned Salinar, and the prescribing information for Salinar is available on request at this meeting. So thank you for listening to that. Please bear with me. So next, it's my pleasure to introduce Dr. Rahul Bharat. Dr. Bharat is a consultant community paediatrician lead on children with complex care at the Royal Cornwall Hospital. He's completed training in epilepsy from Adam Brooks in Cambridge. He's 8 years experience in the management of children with complex neurodisability in the UK and internationally. And he's an NHS clinical entrepreneur and has designed an app to educate parents in the management of day-to-day problems, behaviour, and improved skills in children with neurodisability. This empowers the parents and provides an insight into their child problems along with solutions. So I'll hand over to you, Dr. Bharat.
Thank you, Simon, and thank you for the opportunity, Pravika. And so I'm going to talk about management of drooling in children. And we know how messy it is when children drool, and it affects all aspects of their life and their family's life, travel, moving around, lots of washing, cleaning. So I will try and touch all the practical aspect of it, as well as how we can manage it best in children. So declaration of sponsorship. I've been sponsored by Pravika to deliver this talk. And what we aim to discuss today is to understand the physiology and production of saliva. That's really important, as well as how the swallowing happens and when to worry about drooling and what is the cause of drooling. If we can understand the cause, then we can understand the management and the consequence of drooling, as well as how you can practically assess drooling quickly. And also, if children are on medical management or not, we can say whether the treatment is working, as well as medical management of drooling briefly. So let's just briefly look at how saliva is produced and what are the glands responsible for it.
Saliva is made by 3 main pairs of salivary glands in the mouth: parotid glands, submandibular glands, and sublingual glands. Each gland has hollow tubes called ducts that open into the mouth. The saliva, or spit, flows from the salivary glands through the ducts into the mouth.
So we have 3 major glands which are producing it. And now just talk about what happens when they come in the mouth.
This movement is controlled by the nervous system and involves both voluntary and involuntary muscle contractions. Before food is swallowed, it is mechanically broken down in the mouth by chewing or mastication. The salivary glands secrete the enzymes lingual lipase and salivary amylase. Salivary amylase begins the chemical breakdown of starch, carbohydrates, in the mouth. The water content of saliva helps bind particles together to form a bolus that can be swallowed. Swallowing occurs in 3 stages. The first is a voluntary phase called the buccal or oral transit phase. Here the tongue moves upwards and backwards against the hard and soft palates to push the bolus into the oropharynx. Next is the pharyngeal stage, in which involuntary movements push the bolus through the pharynx and into the esophagus. Movement of the bolus stimulates receptors in the oropharynx, which send impulses to the deglutition center in the medulla oblongata and the lower pons of the brainstem. The brain signals the soft palate and uvula to close off the nasopharynx, and the epiglottis to seal off the larynx. This prevents the bolus from entering the respiratory tract. The upper esophageal sphincter relaxes to allow the bolus to move into the esophagus and contracts to reduce backflow into the pharynx. In the final esophageal stage, the bolus is pushed onward by peristalsis, a progression of involuntary wave-like contractions of the circular and longitudinal smooth muscles of the esophagus.
So it's really important to see how complex this whole thing is. And there is a very minute voluntary as well as lots of involuntary complex cascade of movements which is involved. We will try and see what that means when we come to the management.
Swallowing.
So why do we need saliva in the first place? So we need it because it works to maintain oral hygiene for us. And as we have just seen, there are some enzymes that start working straight in the mouth. So it gives taste to the food. It facilitates in eating. And it also initiates carbohydrate digestion, one of the main reasons why we enjoy some food, and maintain a pH in the mouth and the esophagus. So as we know, our stomach is acidic, but the mouth and the esophagus is not. And one of the main things that the saliva does is control that. So in children with chronic reflux, when they have a lower pH because of reflux, they have more drooling. And in those children, it's really important to control the reflux, and that helps in drooling as well. So something to remember. So how much saliva do we produce per day? It's fascinating to see how much do we produce per day. So it's about 0.5 liter to 1.5 liters. And during rest, it is the submandibular gland, which is producing about 60 to 70%. And during eating, they produce about 25%, or they do the majority of the work. And swallowing, which is occurring about 1,200 times a day. So much of saliva being produced, so much of some swallowing happening. And this shows the amount of involuntary work which happens behind the scene. So when would you worry with drooling? So usually drooling could be normal up to 18 months of age. And it is relatively common for children up to 3 to drool when they are eating. But it is considered abnormal after the age of 4. And then you would think we need to evaluate what's happening here. So when we have a child who comes with drooling and has this criteria of 4 years and above, and maybe has an underlying neurodisability, we need to look what is the reason for drooling and what are the contributing factors for drooling. So there are reasons as well as contributing factors. So sometimes it's the teeth and the teeth hygiene, and sometimes it's the reflux, as I explained. If it is severe reflux and if the pH in the esophagus is low, then both of them can contribute to more saliva production and more drooling. The other things which are important is either you're producing more saliva or you are doing less swallowing. In some children who have poor gross motor development, they have poor head control and poor core control, and they might have low tone around the mouth, so they struggle to close their mouth. So these children will have reduced swallowing as well as reduced efficacy of swallowing. And a combination of reduced swallowing or more saliva production could be responsible for increased salivary production. It is well known that children who have GMCS FCS5 have slightly more severe problems with drooling than children with GMFCS1, which is because if they are more mobile, they have better outcome with salivation. So what is the consequence of drooling? Why bother with it? As I said in my first slide, it is a messy problem. And when children drool, they can be socially isolated, they can have damp and soiled clothes, and a chronic drooling can cause skin irritation around the mouth. And if sometimes with that, as you saw in the swallowing slide, they can have a posterior aspiration, which can result in chronic wheeze or chronic aspiration syndrome. Sometimes they can have a chronic cough, and these children might need thorough evaluation to ensure that they are not aspirating if they have recurrent lower respiratory tract infection and wheeze. So how do we assess? How can we do it in our clinic? How can we do it easily and simply? So we can just ask how much soaking cloth is getting wet, a bibometer. Look at the neurology of the child. So what is the posture of the child? How is the child controlling his head? How is the oral hygiene looking inside the mouth? And how is the dentition? Because that's one thing which can improve, and it's a contributing factor. Is the child able to eat and drink safely? Some children are able to drink thickened fluid. Some children would choke on it. Some children would choke on clear fluid. So it's really important to take that history to see whether this child could be aspirating and could have a primary problem in swallowing. And looking at the neurology of the child in general. So in my experience, I see a lot of children with cerebral palsy or a brain injury having a problem with drooling, but sometimes children with global developmental delay or intellectual disability, they could have low muscle tone around the mouth. They could be having a major problem with their salivation as well. And some of these children need a combination of strategies as well as medication as a long-term management. So this I find really interesting and helpful, and is called Drooling Impact Scale. And it gives me a clear idea of what problem drooling is to the family. So it's just asking simple questions that how frequently does the child dribble, and how severe it is, how severe the parents find it, and how many times they have to change the bib of the child, how offensive was the smell, and is there any skin irritation, and how frequently does your child mouth need wiping, how embarrassed did your child seem to be about dribbling if they're aware of it, and how much do you have to wipe or clean saliva from household items. That again tells the damage it will do to the household things. I hope not computers. To what extent does your child drool after his or her life? And to what extent did your child dribble affect you and your family's life? So I think it's a really good capture of what is the impact of drooling on the family. And if we are doing an intervention, or if we are trying to start a medication in the long run, then it's a really good starting point to see what was it, and after medication, what was it, so we can say what was the impact of giving the medication. And then checking the drooling severity, whether how much the child is drooling and how frequently the child is drooling. I mean, these are just useful tools to kind of quantify drooling, to see how much it is a problem and to see how can we quantify it before we go on a medical management, which I will cover in my next slides. So how do we manage? So we know that we have a child with an underlying chronic neurodisability, and this child is drooling, and we have quantified it to say how much is the child drooling and how it is impacting the life of the family. So how do we manage those children? So the non-medical management are important, and ensuring that the posture of the child is corrected, involving the physiotherapy team, which I believe are generally involved anyway, as well as the speech and language therapy team, and whether there is any oro-motor programs which are available in your area where you can put the child on that program, see if the family can do some of it. There is some literature evidence that it can be helpful. The aim could be for those programs is to aid with lip closure, aid in tongue exercises, which I have seen in my practice to be helpful, and is mostly intended to alter a tongue thrust swallowing pattern, as you have seen in my swallowing slide, that it can, with exercises and stuff, make some difference and can improve the swallowing, but does not reduce the saliva production. So there are some behavior managements of drooling. So some children who have more cognitive abilities than others can respond from biofeedback. What it means is that sometimes some children, the parents can do a bit of a cooing with them. So they can make a noise and the child drool. They can make a noise and the child drool. That in a way reminds the child to swallow and reduce drooling. So it's important that if the child has a cognitive ability, sometimes things like cooing and positive negative reinforcements when they're drooling, as well as biofeedback, could be used for behavior management of drooling. Some of the conservative management is not wiping it, but dabbing it. Now that has shown better impact than just wiping it, and avoidance of trigger, making sure the teeth hygiene and stuff is looked at and maintained. There is some evidence in literature for acupuncture and bandanas, but it's just conservative management. There are some literature evidence of palatal training device in some children. I've seen in one child with cerebral palsy making a difference. So yeah, it's worth kind of discussing with the speech and language. And if you have a drooling team, discussing with them. So now we come to the medical management. And as I said, always think of reflux. If you're not sure, we can do a study to ensure that there is not a chronic reflux, which is contributing to it. And anti-reflux medication does make a difference if there is a reflux. The anticholinergic medications are the main group of medications. So anticholinergic medications are mainly working on acetylcholine, which is a neurotransmitter, which works on the autonomic nervous system. So the way it works is it reduces drooling in children by reducing the production. So there are two main types that we use, or we used to use: the glycopyrrolate bromide, for which we have a licensed medication production till now, and the transdermal hyoscine patch. The problem with the hyoscine is that hyoscine can cross the blood-brain barrier, and there is more side effect to it because it can cross the blood-brain barrier. So sometimes it is less well tolerated in children. So we have moved away in most of the cases towards glycopyrrolate bromide. And there is also trihexyphenidyl, which is a medication which we generally use in children with movement disorders like dystonia. And when children have movement disorder, they can still have drooling. So they will have a problem with their muscle coordination and posturing. And similarly, they could have a posturing with their problem with their swallowing as well. And in that case, trihexyphenidyl is a really good choice as well. So taking into account we always should ensure what is the best interest for the child and parents. And most of these medications are long-term medication. So we need to make sure that we take that into account, as well as age range and indications. So there are other options in children with chronic drooling. So botulinum toxin injections, and I'm aware that Evelina Hospital is doing it, and they have got a good success rate for it. There is also ductal ligation, gland removal, neurectomies, which are, I believe, not very frequently done and always associated with problems, because we still need the saliva. So there could be problems. Now, Selenar is the licensed medication for drooling in children, and we use it quite frequently. But there was a study done in 2017 which compared the hyoscine patch with Selenar, and it was looking at what is the compliance in children using both of them. And it was seen that children using glycopyrronium were more compliant at 12 weeks than hyoscine patch. So as we can see in the graph, it is 55% with hyoscine patch and 82% with glycopyrronium. So it's good, because you want, as a clinician, to give the child a medicine which can make a difference and which the family will continue, and they will see less side effects. So all of these three is seen more with Selenar than what we were seeing in hyoscine patch. There's another study looking at how effective it is and what are the side effects. So it does shows that hyoscine produce more problematic side effects, which is because it can cross the blood-brain barrier. And when it does, obviously, it will have more side effects compared to Selenar. So this is one of the child I would like to talk about. Is one of my patient. He's 5 years old. He's got a global developmental delay, and he does not have a genetic diagnosis yet. So often we can have children who might not have a brain injury, but still have a problem, and their development is behind, and they could still have problems with their swallowing, with their oromotor muscles. And in this child, drooling was particularly a problem for the family, because the child was drooling a lot. So it was initially exercised, some exercise by speech and language team. Unfortunately, there was not much benefit from there. And it was in 2016, was started on glycopyrronium. And the family stopped it because they thought that the child does not like the taste of it. And sometimes it works, sometimes it doesn't. But the drooling got worse. And we sat down and we had a communication. And we looked at what options we have. We used the quality of life and impact measure and restarted Selenar in this child. And this child has been on it for 3 years. And now we have an agreement with the GP. So we are using it on shared care pathway. And the child's drooling is controlled and the family is happy. So that's a really good example of how difficult it could be. And things can go backward and forward in complex children. Thankfully, we did well in this child. So in Cornwall, we have a shared care pathway for Selenar. We have a pathway in which we can identify these children, which we can work on diagnosis as well as some of the symptom management like drooling. So in conclusion, I would like to say that if we have a child with drooling, it's really important to assess, is drooling a problem for the child and the family? And you can use those two scales, which I have used in the presentation, to measure the impact of drooling. Very important. And when you start on medication, maybe 6 months down the line or 1 year down the line, you can repeat that. And that will really help you to understand what is the impact of the medication being or of your intervention being. And try and look at the bigger picture. What is the diagnosis? What are the contributing factors, the teeth, the reflux? Think about exercises or a motor. Think about medication as well. And what is the cause of drooling? That's again important. And whether it is a global development delay or a complex neurodisability with movement disorder, or it is a muscular problem, all of that has to be taken into account when we are giving medication in the long run. And there are non-medical management, which should always be remembered and considered, because not always the families are happy to give long-term medication, and we have to make sure that we get them into the bigger picture. And when on medication, think of benefits and side effects. And the way we do that is we look at the impact and measure the impact. So what are the side effects that you can expect? So sometimes children on Selenar could have constipation, and it's just something that you can remember and check if the child has got any constipation, and then actively treat it, because that will kind of help the child. So this is prescribing information. It's really clear. And basically there is a concentrated dose as well. It does have some side effects, which is written, which I've already covered, like dry mouth, because if it's causing too much stopping of making of secretion, it can cause dry mouth, constipation. Rarely it can cause diarrhea, vomiting, urinary retention. I've not seen that as much. So again, when we start medication, we do give this information to parents, what to look out for. I think that's it, really. That's it from my side, and I'm happy to take any questions.
Dr. Bharat, thank you very much for that fascinating talk. I really appreciate that. There are a number of questions coming through which we'll draw together and ask at the end. But for now, thank you very much indeed.
Thank you.
Thank you. Okay, so our next speaker for this evening is Francesca Napolitano. Francesca graduated in Italy as a paediatric nurse and has spent the last 5 years of experience at Queen's Medical Centre, University Hospital of Nottingham, working on the neurology and oncology ward. She's also part of the Royal College of Paediatrics and Child Health for Quality Improvement Central, sharing best practice. In the last year, she's been working as a paediatric neurology specialist nurse, giving her the opportunity to take care of neurology patients in a holistic way. She's the point between patient, family, school, and the other professionals to make sure that they're delivering always to a very high standard to promote good quality of life in her patients. So, Fran, over to you. Thank you.
Hi, good evening to everybody. So it's a pleasure just presenting my PowerPoint this evening and share my experience with all the audience. So I'm going to talk about how to manage drooling in children with neurological disorder, but this is not about teaching you how to manage drooling, but it's about thinking about it, your experience, comment on it, and sharing with everybody. So I will just quickly say what drooling means, and is overflowing of saliva from the mouth. This is normally in an infant, but is usually stops by 15 to 18 months of age. Drooling can lead to functional and clinical consequences for parents, family, and caregiver. But I'm not going to talk about any anatomic or physiology approach, because I'm just going to talk from nursing, family, and school perspective. So, as already Simon said, I'm the neurology specialist nurse and I'm working Leicester Royal Infirmary at the moment. My role is to look after all the children with neurological disorder and help patients and their family to have good quality life. I'm educating them, providing training for book learn, BLS, and giving some safety and lifestyle advice. We prompt to resolve them issues with them, with of course the support of the consultant, neurology consultant. So what is our relationship as a specialist nurse with a patient, family, school, and community nurses? So I believe most of the audience, if our nurses here, can say that we are really close with the family, because we don't looking after just them neurological condition, but we're looking at them like in a holistic way. So we providing like emotional support, we providing direction towards a professional. For example, if they do have like financial issues, we can direct them how to fill up the disability living allowance. If they struggle with explain their child condition, we might able to communicate with the school or with other professional team, and we can be involved in MDT. So going back to drooling, so how a special nurse can help and support the family, patient, and school in managing it. So the first thing that I always do is a question to myself, how the patient present when they come in the clinic, what they look like, what complex diagnosis they do have. So the patient that I work with, they do have my cerebral palsy, brain injury, neurometabolic disorder. They might have really complex seizures, epilepsy, or they might have a genetic condition. So they might present it to us like in a wheelchair, or they might walk but with some support. They might not be able to talk to us because they are not verbal. So they might express themselves with a few words or with the facial expression. So they might present with NG tube. If you look at them, they might don't have a good stability of a trunk, poor head control, neck control. So because they might have low tone. So it's really essential looking at them and see if they presented like with wet t-shirt, or they might have a cloth, or they are not able to close their mouth. So it is really important having ongoing assessment and be attended to MDT where is possible, so we can see how the patient looks like in their own routine. That's why I'm going quite often. During this pandemic, it's not been possible, but it's usually we are often go out, see patient in the house, or we going at school, and just going in their own routine and see how we can help them in this. Before we go into share information with the family or provide some support, we need to rule it out if this drooling is an issue, case from they had recently dental treatment, they might having teeth or gums pain, which can cause more production of saliva. They might have ulcer in the mouth. So we need to make sure that the patient doesn't suffer of reflux, as Dr. Barrett already said, that can increase production of saliva. So in my experience, during like a follow-up and during like a ward round on the ward, I've been across with a few patients with the drooling issues. And especially one of them, so they had an NG tube, and then at the end, he changed with the peg, which is a tube that goes straight away into tummy. So we noticed that since he had the peg inserted, the drooling started to improve. So the NG tube, of course, was an external object where the body was trying to reject. And every time the NG tube needed to repass, this was really traumatic situation for the child. And in that occasion, and even afterward, we noticed an increase of secretion, which was not able, the child was not able to clear by himself because he had a neurological disorder. So we are, as a specialist nurse, we are the professional that is close to the family and is easily to be in touch with us, because they can contact me on my work mobile phone, or they can email me if they do have any concerns. So we do meet family every 3 to 4 months, but as I said, if they do have any like concerns, they can contact me. We are able to make referral for speech and language, physio, neuropsychologists, if we notice that there is an increase of drooling and that's causing even psychology effect. And it's important to attend MDT because we can get a better idea from the school, teacher, parents, and other professional. So if we move into patient perspective, so we need to ask to ourselves, can this patient communicate? Then if the patient can't communicate, how we can measure that then parent voice is matched with the child condition? So anybody's got any idea? I know somebody might not want to talk. It can just happen. That's fine. So we can make sure that the child condition is matching with the parent's voice, doing, as I said, a face-to-face assessment with patient, attending to the school and attending to them home. So it's essential to have ongoing MDT because we can get idea and views from everybody. Drooling is a common lead to social isolation and rejection because patient can be having like bad breath, they will might having wet clothes, and this can affect them relationship with peers or even with others, and this can affect them self-esteem, which link to a poorer quality of life. For this reason, it's essential to establish whatever there is any evidence on chronic drooling and then prevent it or try to manage it as much we can. So if we go into family experience, so family, they will might just thinking, they worry about their child. They worry because drooling can cause skin maceration, infection, body fluid loss. They can have recurrent chest infection. Children with drooling, as I said, they will might be avoided by others, and that can affect them education as well. So we just need to make sure that we know how the family feels, what this look like for them, and when this started. Family, as I said, they might worry because their child has been in and out from emergency department or hospital because they had frequent chest infection, and that it could be because it's causing from severe drooling because their child is not able to swallow that saliva. So few of the family told me that they're not able to spend a full day out with them child because they might not able to stay in the wheelchair while they're out, because having a seat position, they might not able to clear their saliva, and that is an issue for them and frustrating them. Also, few of the patients, they might having oral suction, which is really invasive, and that can irritate the patient and family as well. They might have reflux, or their children, they might feel sick quite often. Parents, they might feel frustrated by compliance with medication because sometimes they might work, sometimes they doesn't work. And then they worry about dehydration as well. So they worry about dehydration because they're drooling and they lose their fluid loss quite a lot. But I believe that is not really highlighted to the professional because it's one of the late consequences from drooling to compare to aspiration. So parents think about them child identity, how this can impact on their engagement with other peers or with them involvement with other people, how imbalancing this can be, and how can impact on their child's self-esteem. So we need to all remember, as a nurse, we're building up a relationship with the family. So we talking open to them, but we need to listen to them as well. So complication. So patients who drool often experience repeating oral skin breakdown and infection. Clothing bibs became solid and need frequent changing clothes, which can limit family ability to be active out, as I already said, and that's impact on psychology side as well. So Talking to school experience, so I've been in touch with different special needs school, and a teacher said to me that yes, drooling is a quite an evident issues in the school, because children, they might drooling a lot, they will might drooling on furniture, damage the book, and then again, this child might be excluded from all the peers. So how the children can attend school and achieve their full potential with support from their carer and education team. How the school can maintain high standard of quality for this specific type of patient. So is anybody like having an idea? So is it essential work alongside with school? It is important to attend to MDT where is it possible, to see what does helps the child for the drooling and help the teacher how to manage the drooling as well. So especially there is particular, we can ask if there is a particular time of the day that secretion are increased. And community pediatrician goes twice a year in the school just to have some follow-up with the teacher, so they will be able to share their information and highlighting any issues. Speaking language also is involved with the school, with myself, and with the family. They can provide some strategy, exercise, and drooling scale, which will help the person around to document how severe is the problem and how describe what they can do during the school time. So the teacher found easy to describe how severe is the drooling. It is important to know from the school the impact that the drooling having on concentration and on patient learning as well. It is essential to have some observation, looking them in the class, in the morning routine, when patient is relaxing, looking at oral care, oral movement, how they can swallow. Dental care is really important because that can increase the production of saliva. So we are, as I said, we are able to refer to speaking language and even to ENT, just to have an assessment and to check what the secretion looks like. Ongoing MDT is really important, including medical team, teacher, parents, to get more information. This is crucial to analyze all the information and discuss about it to get the conclusion. Sometimes the response can be really various because different person involved, they will might having a different interpretation of drooling. So, as I said, how we can help these patients to achieve the best education while they are in the school. There is an education care plan. This is most supported. This as must provide support to the children with special education need as part of their standard offer to the children. Child who has education needs may also have an education care plan or social care needs, and these are needs be to completed alongside with education. So as an education, as a specialist nurse, neurology specialist nurse, the education care plan that the special needs school send it to us as to completed. It looks like this slide that I'm showing. So they're asking for, of course, detail of the patient, medical history, and then in this we can complete it as like if the patient suffer of a seizure of dystonia, we can add in information how to manage it, what type of medication they're on, how often they use them, and if they do have some rescue medication. Indeed, we can include it if a patient do have drooling issues, if they do have some medication that they use, or if they do managing with some speaking language strategy or exercise. So we also provided the outcomes what we want to achieve, and how often we see the patient in our clinic. So I'm just going to share with everybody, I believe Dr. Barrett already mentioned as well. So for a few tips and action for children with Drool, there are some mouth exercise for few minutes a day to develop oral motor skills. This can be done at school and at home. So it's important to get good posture, especially for children who are wheelchair dependent. The chair might need some adaptation to give a child slide recline position. A small platform can be used on top of the desk to raise the working position for a child who has a particular problem to leaning forward over a computer keyboard or written homework. So we can try to manage drooling with making more aware of like motor skills training, like verbal and touch remind, like telling to our patient, our kids to swallow or touching on the side of the mouth. There is some evidence that these improve and does have some beneficial in patients that do have drooling. So there are some exercises that are presented as part like a play, such as like different texture, like ice cube, electrical toothbrush, which stimulate sensory awareness and exercise to improve lip sealing and tongue movement, and like blowing in the like straw, making lipstick kisses on the paper. So, but we need to make sure that these exercises are consistent, because it will might be not successful if you don't do it constantly. So it's important to do them in the school and at home. So do you think that drooling is overlooked by doctors? That is one of my questions that I just would like to share with everybody. And what treatment can be used? So if anyone has like any opinion or any idea, I can just share in my experience. So I think that, yes, it is overlooked, because most of the consultant, they might focus on beginning on the, of course, neurology disorder. They might focus how to manage the dystonia. They might focus how to manage the epilepsy. And the drooling goes to be highlighted from family, nurse, school teacher, only when it gets severe. So that's why I think we need to improve these. How we can improve these, as I said, with an educational healthcare plan and having ongoing MDT. For children who are themselves aware of the problem, the drool causes a significant functional and social handicap, and both medical and psychology effects are likely to be underestimated. Drooling can be really social embarrassing, and at the same time can cause serious medical complication. For this reason, the problem should be addressed in time. That is why it's essential to treat it. So initially, we can treat with like barrier cream, and we can properly use speech and language techniques. But then what we can do if this doesn't really help, we can use medication. So the medication that I've been across with are these three. So is iosine patch, glycopyrrole bromide 1.5 milligram in 5 mL, and Selenol. So using iosine patch, in my experience, this has not been massively effective. And a parent came to me and said, Fran, I don't think that these patches are helping in drooling for my son. And then they might said, oh, Fran, actually, while I was bathing him today, it just came off. So they don't know how much medication they do absorb. So that is really frustrating for the parents. And also, as Lady Dr. Barrett said, it does have more side effect. So glycopyrronic bromide, 1 milligram in 5 mL. I had a patient who has been on for 4 weeks, and it seems to be okay. But then afterwards, he started to be drooling even more. Then, because he was going on ketogenic diet, which is a diet with low carbs and high fat, the dietitian and ourselves advised to swap with Selenol. And since he started to be on Selenol, the drooling started to improve. So also, it's really important for parents a volume. Why is important volume? Volume is important for parents and patients because high dose of a crushing tablet, they will might limited effectiveness of the medication. Or if it's a liquid suspensions, the patient might spit it out, or might not able to digest it because they do have gastrointestinal issues. So long life shelf, that is another point that parents ask me. They come to me and they might say, Fran, these medication expire too quick. And even at school, these expire too quick. So there is a lot of waste of the medication. So having a medication with a shelf life longer, it's mean waste cost zero and less % of product wasted. So expertise is really important because they can have some common adverse effects like diarrhea or gastrointestinal discomfort. Also, as I said, in few patients that they need to go on ketogenic diet, they might not be able to use the generic glyco, 1 milligram in 5 mL. So, and for medication in special school, it's really important to have like a small bottle, which is useful to reduce the amount of the product wasted. So in conclusion, intervention approach with the therapy and non-invasive exercise first is a good to try it and be involved with speech and language therapist. But then if this is not successful, we're going on medication. And in extreme cases, we can go for the Botox or for the surgery. Also, there is important psychology support because identity and self-esteem is essential in these patients. We need to work together to make sure that we are able to highlight the issues of drooling to improve this patient quality life. It's not a single answer, yes or no. It's just ongoing assessment and information between all the professionals to support psychology and emotionally and medical all this type of patient. This is prescribed information in your case, as already Dr. Barrett explained to everybody. And I think that's it for my point. I hope you enjoyed these sessions with me, and thank you.
Thank you very much, Fran. That's really, really insightful, really informative, and it's great to hear from someone who's got the first-hand experience of working with these children. So thank you very much. Whilst you've been talking, and while Dr. Barrett, if you'd like to put your video and your mic microphone back on. While you've been talking, we've been gathering some questions in, so I'm just gonna turn to those now in no particular order. So the first question that we had in from David Reeve was, can Silenal be used into adulthood? He has a child currently 14 years old on this. So I guess the thing that I just need to point out, I need to reiterate that the license for Silenal is for the indication up to including the age of 17. So anything beyond that would have to involve the discussion of a healthcare provider who's prescribing and get advice on how you would do that. I guess I'd like to just turn that question to Dr. Bharat as to how you might approach that.
Yeah, again, it's a really interesting question. And again, it depends on the age of the adult, their underlying condition, and their treating physicians. And because we don't do adults, we only do children. So it's kind of out of our remit to answer this question. But yeah, it's a really interesting question. Thanks. But maybe an adult a physician or a neurologist should be able to say what they are doing in their practice.
Okay, so we'll just move on to the next question. Straightforward question for you, Dr. Bharat, and it's, could you tell everybody what the name of your app is that I mentioned in your introduction?
Yes, so this app is called Brain Rakshak, which means a brain protector. And basically, we are using as a pilot at the moment in India, and is going for a study in Truro from September. It's still, we're going through validation and other things in the UK. But we have seen really good results by actually decoding where the developmental child is and what kind of play and methods to use at home and how to empower parents with it. That makes a huge difference. So thank you for the question.
Thank you for that. And how will we find out more about the app as and when you get further down the stages with this? Will you be telling social media? Is there a platform you have to inform people? Yeah,
so the website is called ispectrum.com. So we are working on children on the spectrum and children who have neurodevelopmental impairment. And we also have courses for school as well as parents, so they can do digital online courses and use the app for information. And that is all going through CPD accreditation and stuff. So yeah, all the information will be on ispectrum.com, hopefully from September.
Thank you very much. Thank you for that. Good. So the next question, is there any link between glycopyrronium use and an increase in seizure activity for children with epilepsy? Dr. Bharat, do you have experience of that?
Yeah, so basically epilepsy is a very broad term to say what epilepsy it is, what type of epilepsy it is, why the child is having a seizure, whether it is a primary generalized epilepsy or an encephalopathy. So sometimes when you have, I recently saw a child who had a regression, and when we did an EEG, the child had an encephalopathy going on in the brain, and the child started drooling more and more and more. So in that case, I have treated the encephalopathy, and I'm hoping that in 8 weeks' time, we can assess whether treating the encephalopathy is going to resolve or reverse the regression in the child, and whether we can control the drooling and the regression in that way before we can go and treat the drooling primarily. So, I mean, it's often really complicated. There's no direct relationship between glycopyrrolate worsening the epilepsy or benefiting the epilepsy. But what is more important to understand is that what is the cause? Is the epilepsy getting the drooling worse, and controlling of epilepsy in a way that the child is not regressing but progressing.
Okay, thank you very much indeed. Next question from Sander Burbeck is, any interactions with epilepsy medications reducing effectiveness that you've observed in practice? I guess
I don't think so, no.
No, okay. I don't really have anything additional to add to that. So just moving on from another question. Someone's saying, I found hyacinth patches contribute toward urine retention in some children. do other people find the same? When I've removed the patch from one child, the urine output improved as well. So I guess, but Fran, have you any experience of that?
Yes, I've been experienced with the two while, because I've been working in home care before I have been a nurse, and I've been experienced with the two children with retention of urine when they use the icing patch, and since they've been removed and went on different medication, then that was resolved. So yes, I can confirm this.
Okay, thank you.
I believe Dr. Barrett with my
Yeah, I mean, as I said, all of these anticholinergic medications are smooth muscle dilators, and hyoscine patch can cross the blood-brain barrier, and it will have more side effects like urinary retention. So even if you read about Salinar, it gives about urinary retention as one of the side effects, but we don't come across it because it does not cause in the doses that we are giving in children. But unfortunately, hyoscine patch has a higher chance of it. So because it is crossing the blood-brain barrier, and both are working in the same way, smooth muscle dilatation. So it will be one of the side effects to be expected.
Yeah, and you would concur with the contribution towards constipation as well as a known side effect. Okay, thank you. Next question is, how do you deal with skin reactions to patches? There's a series of questions on the hyoscine patches here. Fran?
So I've never been across to a reaction to icing patch. But in the case where, like, if they do react, the one of the option to do it is just to stop it and then go for Salinol. So that will be my advice, just because it will be quite irritated for the patient and not really comfortable and not nice look as well. So yeah.
Okay, thank you. And Dr. Barrett?
I think anything which is causing a skin reaction, maybe allergy, maybe not, you would remove it and look for alternatives.
Yeah.
Okay, thank you. Next question from Anna Portales. When does suction become a consideration if drooling is excessive, and are there any guidelines around this?
Yeah. Fran, do you want to answer it from nursing perspective?
So from nursing perspective, I know that suction, a patient that can link to produce more saliva. So that's why we recommended to not prompt and suction patient. So, but then if the patient is really struggling, for the first action to do is to try to manage position, posture, then medication. And I believe is really the latest action to do with suction patient.
Yeah, I mean, what is really important is that whether suction is needed acutely or long run. Yeah. And if the child has got an infection and a lower respiratory tract infection, they're likely to produce more secretions, and whether the child is in hospital needing oxygen. So it's all about the setting, it's about the posture of the child, it's about the oxygen saturation and what is that extra salivation doing. And unnecessary suction is going to cause more production of saliva, and the pressure in the suction is also important. So it's a lot of things in one question. But it's really important to understand the setting, which is most important. Unwell child or a well child.
Yeah, I will say the same. In acute situation where a child doesn't breathe properly, he needs oxygen and he's drooling a lot, then it's okay to suction. But home environment, if he's just drooling where usually using oxygen, it's better to do exercise first, position parents, try to drooling come out. So yeah, I would not advise as a like.
Okay, thank you very much. Next question is, I look after a child who has epilepsy, who's on a ketogenic diet with difficulty on controlling secretion. He's taking maximum dose of omeprazole, which is not helping. He's 4 years old. Would Salinar be an option?
Yes, so that's what, sorry, can I ask these? Because I believe I mentioned in mine, it's like, yes. So in our patient, especially in the last patient a couple of weeks ago. So he started on ketogenic diet, and looking to excipient inside, it looks like that doesn't have carbs, and then even doesn't have sorbitol, which that is really helpful for patients that they might have gastrointestinal issues as well. So yes, I will definitely recommend the Salinor. And also it's important to have Salinor an hour before a feed. That is, there is some evidence that's improved the absorption of the Salinor and improving in the drooling.
Thank you. Dr. Barrett, anything you want to add to that?
I think, again, a difficult situation. Child is on ketogenic diet for epilepsy, and I've been told that is on maximum dose of omeprazole. I would like to have obviously more information of what type of epilepsy it is, what's happening. Definitely Salinor should be used as an option, and there is no contraindication at this stage to not use it. But again, looking at the bigger picture, if ketogenic diet is not working, I'm thinking as an epilepsy specialist, thinking where are we going with the management? But yeah, Salinor definitely for secretion management in this child, a trial is needed. Yeah.
Okay, thank you very much. Next question is, what's your experience of use of Atrovent inhalers for the management of secretions?
So Atrovent inhalers, again, are anticholinergic medications, and it is shown to, it's used in asthma, and it is shown to help with the secretions. But the dose that we are using, the administration as an inhaler, there's no evidence that it can be used in our group of children who are drooling, and there is no studies done as well. And it's not a licensed medication for this. So yeah, even in children with chronic neurodisability, there is no evidence of this. But yeah, it is of the same group, but not like this. No.
Okay, thank you. We've then got a few questions here. I think we've probably largely covered these. Can you thicken glycopyrronium, or does it reduce the efficacy? The thing I'd say is I wouldn't recommend adaptation of the product. It's formulated in that way to enable effective dosing for the child. So any addition of additional excipients, I wouldn't recommend for the clinical profile of the drug, but also the addition of additional excipients can result in some safety concerns for some children. When medications are crushed or mixed with food, I think we've covered that one as well. The fact that should be done under very, very careful caution in extreme circumstances as well. Next one, it is tricky to get the dose of Salinor right for each child, or is it tricky to get the dose right for each child? So looking to share your experience of how long that can take on stabilizing the child on Salinor, and how frequently would you review the medication, and how do you decide to go up in the dosage each stage? So perhaps Dr. Barrett could explain how that's worked with children in your care.
So usually when we start any chronic medication, in my practice, I kind of define the problem that I'm addressing, and I try and reach a negotiation to say what results can we expect and what are the undesirable side effects. And with Salinor, I would give at least 3 months for the child and the family to assess the situation. And unless there is any side effects or any problems which are really unexpected, I would actually give it for 3 months. And then once the child is stabilized on the dose and liking the preparation and the impact on the child, we will just carry on, and based on how the child responds, we can do 6 monthly or yearly review to say whether we need to change the dose or whether we need to change anything, or have a trial of sometimes the parent want to have a trial to see whether the child needs it or not. So yeah, again, 3 monthly, 6 monthly, 12 monthly review based on the diagnosis, based on the underlying condition of the child. So if you have a child with GMFCS5 and you know that this child is not going to come out of the medication, this child needs it, then you will just carry on. So it just depends on the situation.
Okay, thank you very much. And Fran, if you've got any experience you'd like to share on that?
I totally agree with Dr. Barrett. Yeah, it's every 3 months that we probably assess, follow up a patient and review it. Yeah.
Okay, thank you. The thing I'll just add to that is we in Pravika have developed a Salinar dosing app to help with this. We can put the QR code into the chat so that everybody can get access to that. It's also available on our website, pravika.com, so you can find that there. It's quite an easy little app, download to your phone, that can help with dialing in the correct dose and also transferring children from one form to another. So got the suction one I'm just going through. So I guess a fairly broad question here, and that is, what would you, I guess to both of you in turn, what are the biggest challenges for parents and carers of drooling in children? How would you go about trying to summarize that?
Yeah, I would say most children who are drooling have lots of problems, developmental problems, behavior problems, could have epilepsy, and drooling makes it worse because it does restrict their movements. It does makes them do a lot of washing. It can be spoiling their things at home, and embarrassing for them. So it has a lot of it's just add on to all the problems, because it is obviously seen. So taking that edge away in that child, while you might not be able to take or treat other things, could be one of the benefits that the family need, so that they can socialize more, meet more, spend more time with the child. And yeah, so it does have for me, it's a combination of things, and it should have an impact on changing the life of the child and the family, as well as reducing the drooling and looking at a holistic picture.
Thank you. And Fran?
Yeah, as I said, Dr. Barrett, it definitely will improve some part of quality of life in this complex child. And as I said, I've been across with a patient that mom just came to me and said, Fran, I couldn't spend a day out because I know that he's just have dystonia movement, but his drooling is really affecting. He can't stay in the wheelchair for more than half an hour. So I think in reducing these, taking these off, it will give some relief and make this family have some social life even outside and meet with all the children. So yes.
Okay. Thank you very much. I think that brings us largely to the end of the questions. I think we've answered all those that are on the screen. So with that, I'd like to thank you once again, Dr. Barrett and Fran, for your time preparing and delivering a very interesting evening for the participants. Sincere thanks for everybody for your participation and posing some great questions for Dr. Barrett and Fran, for joining us, and I'll wish you a very pleasant evening. Thank you very much.
Thank you.
Thank you.
I must say that we had a very learned audience, and we had some really nice feedback and some really nice questions. So I thoroughly enjoyed, being in this session, and thank you for inviting me.
Yeah, thank you very much as well. So it was really interesting and nice sharing my experience with everybody.
Thank you. Thank you very much.
Yeah.